Again, non-opioid clinical pharmacology and chronic pain management is our subject today. I mentioned grant support, also of clear relevance and shouldn't intimidate any of the prescribers on a regular basis, but many of the non-opioids that I'll be referring to are off-label per FDA labeling requirements for pain, and much of the pain treatment that we offer in general has limited or no randomized control trial evidence-based support. And we'll be getting into that very, very shortly. Objectives are to understand why chronic pain medication management should not be opioid monotherapy. Also know the value and potential side effects of the three key groups I will be discussing: the anti-inflammatories, the antidepressants, predominantly the tricyclics, but some on the SNRIs, and the anti-epileptics or anticonvulsive drugs. I will just touch on cannabinoids, since that always comes up, but we do have a separate curriculum component devoted to the cannabinoids. And then, most importantly, I know the role, value, and frankly, how to do it in your clinic for non-drug options for chronic pain management. So first, how compelling is the evidence base for opioids? Isn't it a known fact that opioids, the more you give, the more results you get, and we have wonderful efficacious for chronic pain management and opioids? Well, absolutely not. So when we challenge our non-opioid adjuvants and say, well, we don't have the evidence to support that, we're actually running into the same conundrum for the clinician that really is called out by recent NIH and HRQ review that is underway. It's also going to be identified as well as a conundrum for policy from the Centers for Disease Control that is going to be releasing their guidelines come the first of the year. This is published in the Annals of Internal Medicine this past summer. Just calling out a couple of names, we refer regularly to Roger Chow from Oregon Health Sciences, who's done a lot of work on opioid efficacy, and Dr. Judy Turner, our faculty here at the University of Washington, and actually here in the clinic on Tuesdays, who did a very extensive evidence review. And bottom line, evidence is insufficient to determine the effectiveness of long-term opiate therapy for improving chronic pain and function. Evidence supports a dose-dependent risk for serious harms. Bottom line, minimal evidence for effectiveness, if any, most low quality, effectively no evidence for the higher doses, and significant evidence of harm. So when we're making decisions about opioids, remember that there is very limited support for using these as well. So if not opioids, what then? Common question comes up to me when I'm speaking to primary care audiences, either in workshops, large audiences, or even visit to clinic sites. This raises the term of the frequently used word multimodal analgesia. This is part of the standard parlance that we encounter, and I've listed a number of the drugs and strategies that come out of the pharmaceutical and drug and device categories. Multimodal means using more than one therapy to accomplish the goal. And I've struck out opioids here just because we're going to look for non-opioids. This brings us the NSAIDs, anticonvulsants, antidepressants. We fly by the NMDA antagonists, which would be ketamine, because there's very little evidence right now in the outpatient chronic pain domain, although there is some information trickling in. And cannabinoids with a question mark, because the evidence there is also very challenging. And just we'll breeze by regional anesthetics and neuroaxial anesthetics. But even more importantly, let's look at multimodal analgesia as including non-drugs. And I've been dismayed when I look up multimodal analgesia by PubMed searches and the like. All I come up with drugs. But if we're talking about analgesia, let's not forget the tremendous effectiveness of a lot of non-drug options. The techniques listed on the left, we've had a lot of conversation here on a regular basis about motivational interviewing, I discussed one of our last didactics very recently about the value of good, clear, empathic listening and making connections with your patients to be able to guide them through the very difficult journey of gaining self-management techniques. There's certainly no question here now that Dr. Jim Robinson's back after his recent break and vacation. We've learned quite a bit about exercise and mobilization and other techniques that are available in physical strategies, physical therapy strategy, and again, patient education. And, of course, cognitive behavioral therapy and coaching interventions with evidence to support improvement in addition to anxiety, but lessening pain intensity, reducing opiate utilization, improving our patient treatment satisfaction and adherence, and accelerating recovery as well as other benefits. I've taken the liberty here of making up a new term calling comparative effectiveness, or comparing effectiveness would be a better way to put it. When you look at the available data, and there is some, and I have a short list here of references, to comparing how much you would expect on average to reduce pain intensity with an opioid-based therapy alone. This is opioids only, less than 30%. The data for the tricyclic antidepressants and the SNRI antidepressants, about 30%. Anticonvulsants, about 30%. Cannabinoids, at best, about 30%. Acupuncture, more than 10% when added. This is the best published evidence of reasonable quality. That number is probably going to trickle up as we get more studies done, and the cannabis data will become a little bit more robust as focus is more directed there due to more public demand to get access rather than the push of science. Here again, cognitive behavioral therapy and mindfulness, this is using completely different metrics, different template, different population, and so you really can't compare these studies side by side. So that's my apology here. But the variable reduction in surrogate measures for pain intensity are between 30 and up to 50%. Graded exercise therapy variable, some publications as high as 50%. Sleep restoration about 40%. And hypnosis, manipulations, and yoga, variably difficult to get data in a chronic pain population. But again, there's clearly a positive effect that's evidence-based. So, as I've mentioned periodically in other forums, that though we have all sorts of problems with opioids and challenges prescribing tricyclics and anticonvulsants, certainly with cannabis, there's never been a reported overdose of mindfulness to date, so we can compare risks, benefits together again in this same conversation. So, moving on to sleep. I consider this the first domain of a clinician encountering a patient with certainly chronic pain and also acute pain. Pain interrupts sleep. Interference with sleep is one of our pain tracker metrics that we ask our participants to present when they present to us in this forum. It is the first, typically the easiest. Sometimes it's a bit refractory. The goal is to get 6 hours or more of sleep. There's data at 5 hours or less, doubling pain intensity thresholds and volunteer short-term studies in experimental pain testing. But 40 to 50% reduction can be achieved in visual analog pain intensity in some studies with just getting your patient to sleep. So what do we frequently use in management of sleep? Unfortunately, benzodiazepines often come up. They're quick. They're easy. They make the patient very happy because they work really well right away, but they are not recommended in any guideline or by any bona fide expert as appropriate in management of chronic pain, certainly when you're co-prescribing with opioids. Dependency occurs. Really, if you're needing a short-term in an acute pain setting, really cutting it off by 4 weeks makes a lot of sense to prevent clear dependency on those drugs with your patient. The Z drugs, I think they did pretty well with all the Zs. No doubt the marketing people thought Zs are good for people to sleep. How we call them. So Zolpidem or Zaloplan. This is Zaloplan is Sonata. Zolpidem is Ambien. For example, are commonly used drugs. They are generally recommended for short-term. They can become long-term drugs, and we frequently see this in patients who are referred to our practices. We don't have any significant data on benefits as far as analgesia. Their risk of overdose is lower, but at high-dose sustained use, the interaction with sedating drugs such as opioids becomes a significant concern. So this is the options that I typically recommend first line, and unless there's a contraindication, I will use a tricyclic category drug, a tricyclic antidepressant drug, because they capture the trifecta of treatment. Analgesics, we'll spend some time about how they work as analgesics. They are antidepressants, demonstrated to be effective in depression, and many of them have antihistaminic side effects and therefore induce sleep. No significant dependency. And if you look at sleep data on slow wave sleep, which appears to be the magic sauce for getting our patients to recover from the difficulties managing their daytime awakeness and to get the analgesic response, slow wave sleep is very important. Tricyclics actually do not interfere with slow wave sleep. The other drugs that, and I failed to list this here, I didn't update this slide, I apologize, would be the gabapentinoids, or gabapentin because it's sedating. That also is good on slow wave sleep. The other drugs do not appear, including the Z drugs, and absent in the SNRIs. Benefits as far as slow wave sleep, and the benzodiazepines similarly disrupt slow wave sleep. So we want a quality of sleep as well. Melatonin, excellent agent. I was surprised a couple years back listening to a lecture on that most of us have been historically prescribing it wrong. We say take it before you go to bed at night. The sleep experts recommend for difficulties with sleep initiation, in other words, getting to sleep, it needs to be taken 2 to 4 hours before to set the brain up in preparation to get to sleep. Ramelteon is an agonist, a melatonin agonist, very expensive, third-tier drug. It's much less effective than we'd wish, but that's another prescription option that you may be considering. Benzodiazepines for sleep are not recommended in chronic pain. I'm repeating this slide again because this is such a key problem in managing patients with chronic pain and a key problem in co-prescribing. Lack of evidence for sustained benefit, a rebound insomnia, oversedation when combined with opioids, and it just complicates tolerance, dependency, and addiction concerns. And when tapering our patients off opioids, we have found, frankly, tapering opioids down is easier than tapering benzodiazepines. Patients really have a lot of difficulty dose reducing these agents. Don't forget acetaminophen. It's effective. We don't have any published data on, like I was showing before, none at all, on acetaminophen in terms of efficacy and long-term effectiveness of reducing pain intensity. But our patients do report that they get some relief. There was one long-term study on knee osteoarthritis which found it less effective than opioids and found it less effective than anti-inflammatories. Anti-inflammatories were also less effective than the opioids in management of this one study. But be that as it may, pay attention to the total dose in patients who are under the age of 60. This would apply over the age of 60. The current recommended dose is less than 2 grams a day. Find out what they're taking over the counter because a lot of cold medications and sleep medications that are available in combination will have acetaminophen. And then many of the prescribed opioids have acetaminophen linked in combination, hydrocodone, codeine, and oxycodone in particular will have acetaminophen. So add that up, make sure the number is under 2 grams for younger patients. And any patients using alcohol, so take an alcohol history together. And interestingly, when combined with anti-inflammatories, renal function has a bigger hit. So frequently we'll say, well, I'm using an NSAID, it bumps into the kidneys some, so I'll just add acetaminophen. But that actually will increase the toxicity on renal function in patients who are on chronic NSAIDs. Chronic NSAIDs are typically less effective for management of many of the pain conditions we treat because those pain conditions have become centrally sensitized, and NSAIDs work in the setting where there is peripheral nociception in a hyper nociceptive milieu, meaning an inflammatory environment that is activated and sensitized the nociceptors. But once that process has entered the central nervous system and it's more of a neuropathic or a central pain state, very unlikely to get benefit. And they all raise blood pressure, both the cyclooxygenase 1 and 2. By the way, 1 and 2 are equally analgesic. There's no difference between old-fashioned cyclooxygenase type 1 drugs, which simply refer to non-selective versus the COX-2 selective. All increase cardiovascular risks, hence the new warning on prescribing that even at fairly young ages and even with intermittent short-term exposure, there appears to be a population-based data that elevates cardiovascular risk associated with NSAIDs. It doesn't mean you shouldn't use them. Just pay attention. I'm always struck by being a primary care internist, how many patients I elevated their blood pressure. It made their blood pressure refractory to all my antihypertensive drugs. And it wasn't until I had that dumb moment when I realized I'm giving an NSAID, take it off, and suddenly the blood pressure is well controlled. So this is a little clinical pearl. And with the risks of cardiovascular toxicity related to NSAIDs at this point unknown as to what the precise cause is, I've speculated that it's really getting that blood pressure up. Published last week as a practice guideline. I think it was the New England Journal of Medicine or the Annals of Internal Medicine identified that the targets for blood pressure now should be 120 or systolic or less. And I'm speculating that the NSAID risk is that they're concurrently raising the blood pressure. I don't know that, but that's a reasonable inference, I think. Renal adverse effects, they reduce blood flow because the prostaglandins that we're suppressing will protect against renal ischemia, so we're interfering with prostaglandins, and therefore we induce renal ischemia. There's some nephrotic syndromes that have been associated with it, and those patients on potassium-sparing diuretics will also be expected to have a hyperkalemic response. It may not be significant enough, but that sometimes may be explanatory for you with your prescription. Bone metabolism, complicated, unclear, dubious effect. There's some anti-resorptive evidence in animal studies. Human studies, infusion are somewhat compelling. They don't drive me away from thinking about that in spine fusion and other ankle and other joint fusion procedures. However, it may be reasonable to avoid infusion procedures. How to monitor them? No guidelines published. I, in my practice, get a baseline creatinine to start. If it's at all elevated or other factors may be present that suggest it may be a factor, I'll get a calculated GFR, which nowadays comes up, or even proceed with a creatinine clearance. Long-term does make sense to get annual creatinines. Patients are on chronic NSAIDs. Corticosteroids, just a few words. They are excellent acute anti-inflammatories. Don't forget, NSAID is non-steroidal anti-inflammatories who avoid some of these toxicities, glucose intolerance, the agitation, delirium, maybe the bone mineral metabolism, probably, and certainly no adrenal suppression with NSAIDs. But the corticosteroids have their problems, and as an acute anti-inflammatory, it would be reasonable to consider a short oral course of a corticosteroid, and when that fails, this is very appropriate for radicular pain isolated to a dermatome that is consistent with imaging. That selective injection would be reasonable, either transforaminal, i.e. nerve root sleeve, or epidural This does not apply to central canal stenosis for the epidurals. That's now been disproven as being terribly effective, and joint and tendon injections. I'm going to jump over to the anti-inflammatory categories. So, the gate theory of pain was brilliant. It's over 50 years old in terms of its original invocation. And I think at this point, perhaps committing heresy because we're not really quite sure and not being supported by strong scientific evidence that this is the one gate. But the descending inhibitory pathways, here's the peripheral input, it goes up, and the central nervous system, cortical structures, periaqueductal gray structures, the rostral ventral medulla, and then back down to the dorsal horn. These are key steps where norepinephrine, one of the monoamines, monoamines are the broad class of antidepressant drugs, is a principal neurotransmitter which facilitates inhibition. And this is thought now to be the principal domain you're attempting to modulate in terms of a monoamine at making more robust the inhibition that will tell the central nervous system that this input from the periphery is no longer important and it's time to move on. The descending pain pathway system processing disorder, this is a way of describing centralized pain states or central sensitization. This is work published by Mohammed Yunus. Clifford Wolf has done a lot of work on this. And our colleagues at Swedish Hospital have Dan Claw from the field of fibromyalgia, actually speaking at the Grand Rounds tomorrow night. So there's a lot of work being done in central sensitization, predominantly initially about fibromyalgia, but we see this syndromic cluster regularly. This is the positive review of systems you see in your patients with chronic pain, where they have irritable bowel, tension headaches, migraine, temporomandibular disorders, myofascial pain, chronic pelvic pain, and interstitial cystitis. This is a syndromic diagnosis which will give you a clear tip that this process is unlikely to be nociceptive in the periphery and more likely to be a response to chronic central nervous system processing disorders for which there is a significant evidence-based support that the antidepressants and the gabapentinoids will play a role. What data do we have now? Clinical trials for tricyclic antidepressant effectiveness. Numbers needed to treat NNT means how many people you expose to the drug to get a 30% reduction in pain intensity. And of course, we talk about function, quality of life, mood. So this is that pesky pain intensity question. But just using that with those caveats, postherpetic neuralgia, 1 out of 2 to 1 out of 3. Diabetic peripheral neuropathy, almost 1 out of 1. You'll be able to accomplish that to 1 to 1.5. Atypical facial pain, meaning not trigeminal neuralgia, but facial pain that may be in the distribution of the trigeminal nerve, but is daily and constant, 1 out of 3. Fibromyalgia and central pain states under 1 out of 2. There's less clear evidence in osteoarthritis, back pain, chronic pelvic pain, and headache, although the current interstitial cystitis guidelines are currently recommending tricyclic drugs and the gabapentinoids as early line therapy after other anatomic biological pathologies identified. Headache disorders, certainly gabapentinoids, anticonvulsant drugs, general and antidepressants are useful. Less clear for mono and polyneuropathies as a primary neuropathic pain state rather than diabetic peripheral neuropathy, post-op breast cancer pain, and I do not include post-chemotherapy pain is also apparently less effective in response to tricyclics in a number of studies, including some as recently as last year, failing to find evidence. And they're reasonably solid studies, although they all have short follow-up and small populations. Other clinical effectiveness trials strongly are effective for diabetic peripheral neuropathy for SNRIs and fibromyalgia. The 3 SNRIs, the venlafaxine, duloxetine, and milnacipran, demonstrating effectiveness. In fibromyalgia, the SSRIs have no benefit in pain intensity. They do help mood. And many trials have been evaluating it in diabetic neuropathy, and it not as robust as the SNRIs, and it does not appear to be the SSRIs effective in peripheral neuropathies either. So you want something with N in it, like norepinephrine from an SNRI, or any of the other tricyclic drugs. This is, again, please give me liberty to I spent quite a while trying to get the norepinephrine to serotonin ratios in these category of drugs. Most of it's done in tissue fibroblasts, which is a big jump from the neuron and the brain. And a lot of this is proprietary. But as a general rule, the more norepinephrine, in my mind, is better. Hence, maproteline, which is a pure norepinephrine reuptake inhibitor, or dizipramine, nortriptyline, and protriptyline, which are highly noradrenergic, and the other tricyclics. Mirtazapine actually increases the release of norepinephrine and serotonin rather than reuptake inhibit. But again, these generate a noradrenergic effect. The SNRIs, and if you look at the norepinephrine ratios, they're much higher in the milnacipran, which is why that's Savella. Why in the U.S. it's approved for fibromyalgia, actually rather than depression initially. And here's Cymbalta, heavily promoted, but is still predominantly serotonergic, and venlafaxine. And again, here are the predominantly serotonergic drugs. So top end is, in my view, where you would begin to look in terms of adding these agents to your population. Side effects are important. For the sake of time, you have this as a reference. Big concern, of course, is in arrhythmias. So if a patient has a known arrhythmia condition, history of fib flutter, history of recurrent paroxysmal tachycardia, or if they're on an anti-arrhythmic drug, they are not recommended, the tricyclics. The SNRIs have about half the arrhythmogenic potential and half again for the SSRIs. So you're having to make some compromises with patients with some rhythmic problems by moving away from the TCAs. This would be a good circumstance for using an SNRI in the management of the neuropathic pain states. The antihistaminic, this should be anticholinergic blockade, So this is anticholinergic dry mouth, urinary retention, and constipation. These drugs are used with caution with patients who have BPH and already may have a constipation problem. The antihistaminic side effects help people sleep, but that puts on weight. The norepinephrine does tend to produce orthostatic hypotension, so these agents need to be considered with some caution, not absolute, but a relative consideration in that circumstance. Serotonin syndrome, pretty unusual. Sexual impairments, which may be more related to serotonin than the norepinephrine component. Seizures with high-dose bupropion. And tramadol in overdose, or tramadol in the setting of an antidepressant because of the serotonin component of tramadol, also of concern, and production of mania and suicidality in all categories from a psychiatric perspective. The myth of skeletal muscle spasm. This is a Landau. This comes from Johnson's 1989. I think it remains a myth. It was a myth then, is a myth now. And you can read the quote, but basically it says the more they advertise, the less likely you need to use it. I used to tell it to my kids when they wanted products that they see advertised. See, it's being advertised. I said, see, you don't need it, because if you needed it, you wouldn't need to be advertised. But be that as it may, I think carisoprodol or Soma in red, do not use. It is the prodrug to meprobamate, which was withdrawn from the market based on its lack of efficacy and its significant harm. So it makes no sense to give the prodrug. Methocarbamol, really unclear. Our patients like it. I think it relaxes them some as a sedative. It relaxes us because we're doing something. I don't think it relaxes muscles. I could not find any evidence in back 20 years of any methocarbamol data on long-term benefit in persistent pain. Now, orphenadrine is a little interesting because it has some NMDA antagonist role. Again, not well studied long-term. Don't forget cyclobenzaprine is a tricyclic drug, Flexeril. It's a good agent to use when your patient absolutely refuses to take one of those psychiatric drugs. So they'll Google it and look it up, and it'll be a muscle relaxant, and so they'll take it. But its mechanism of effect is like a tricyclic, so be attentive to that and don't mix this with antidepressant drugs, and be cautious about dose. Benzodiazepines, are they really muscle relaxers? Stiff person syndrome is the one exception. I, after 35 years of practice, did see a case of that. But I don't think we see much stiff person syndrome in our routine practices. Perhaps that would be an exception. If the patient, I thank Dr. Robinson for teaching me this about 15 years ago, spasm is not spasticity. Spasticity is an upper motor neuron event. Therefore, antispasticity drugs, such as baclofen or tizanidine, are effective, but these are not spasm. This is true increased muscle tone, true spasticity that you're managing. Word on gabapentinoids. What's their efficacy data? We gave you before the tricyclics. Let me just compare the pregabalin data for peripheral neuropathy. Remembering the tricyclics are, for peripheral neuropathy, about 1 out of 2, maybe 1 out of 3 numbers needed to treat. So the numbers needed to treat are less satisfactory even at 600 milligrams of pregabalin in the both the Freeman and the Hauser data. There may be newer data that I overlooked, but this is still, I think, the experience that many of us have. And I think we also have this pesky problem at 600 milligrams of pregabalin. Our patients will have all of these top 3 side effects: weight gain, edema, cognitive slowing, and sometimes dizziness and ataxia. So these are significant concerns, and that's why the numbers needed to harm become a problem. And so that's 1 out of 6 to 1 out of 14. You're going to run into difficulties on numbers needed to harm. And in the fibromyalgia data, you got to get these doses pretty darn high to get the benefit. We use other anticonvulsants for headache disorders regularly, both the gabapentinoids and the sodium channel I'll get to in a moment. But visceral hyperalgesia syndromes, I am a regular user of both the antidepressant drug and the gabapentinoids. For chronic pelvic pain syndromes, they are now being listed in the evidence-based treatment guidelines for interstitial cystitis and chronic pelvic pain state. And there's no data on chronic abdominal pain that in the clinical trial basis that is robust. We will announce again more formally, but on the December 1st, I believe it's a Tuesday, Dr. Gephardt, Jerry Gephardt is coming from the University of Pittsburgh. He is a renowned career scientist on visceral hyperalgesia syndromes. He'll be here at the University of Washington. Stay tuned. He's going to give a lecture 5 to 6 in the afternoon. I believe it's on December 1st. We now routinely in the hospital, in the perioperative at both Harborview and the Medical Center, give a dose of gabapentin preoperatively, because there is at least animal evidence and some anecdotal and early trial evidence that supports reduction of postoperative hyperalgesia after thoracotomy and abdominal and pelvic surgeries. The sodium channel blockers, the classic are the canes. Lidocaine is a sodium channel blocker. So are the anticonvulsant drugs. Carbamazepine, evidence-based, a lot of published support, no randomized clinical trials in trigeminal neuropathy. And oxcarbazepine, very similar. There are reasonable trials, I'd say low quality data, because they're not randomized, controlled as well as we like, but for trigeminal neuralgias and multiple sclerosis as well. And lamotrigine has been looked at in trigeminal neuralgias, in HIV peripheral neuropathy, and some in diabetic peripheral neuropathy. But again, the robustness of the evidence doesn't prevent us from trying it in refractory cases. It works by discriminating between resting and normal state neurons by reducing their overall activity. They, however, are tricky. This is why they are harder to prescribe than the gabapentinoids, because of this pesky list of side effects. SIDH, you have to get a lab test. LFTs, you got to get a lab test. Neutropenia, you got to get a lab test. Hyperammonemia, you got to get a lab test. Metabolic acidosis. These things you need to monitor with blood testing. They apply to individual potentiality with all these, but these are listed with all your sodium channel anticonvulsants, and you can't just ask your patient if they're tired, if they've gained weight, if they feel their balance is off. You actually have to evaluate it. So it's just harder to manage, and the evidence, again, is really confined to these top 3 drugs. Topiramate is associated with the kidney stones. This is what the numbers here are linking, which are the principal side effects that you might see. But there's the headache evidence is actually not compelling, although we use it, and it does curb appetite in some patients. Lacosamide is a tier 4 drug. It may be tolerated in circumstances because it's more selective for dysfunctional sodium channels. So diseased sodium channels are sort of stuck open. It may be more selective. No good data, again, to support that. Okay, last slide before some summaries. Cannabinoids, they are definitely activate a G protein effect at multiple sites. Apparently, there are more cannabinoid receptors in the central nervous system than any other neurotransmitter, so they're important. They are postsynaptic activated, so it's not before the release, but they will prevent continuous presynaptic activity by their activation. So they're kind of circuit breakers in their effect, so they work a bit differently than the other drugs we use. The best evidence is in multiple sclerosis and in cancer pain syndromes. As far as pain is concerned, effective for nausea for both as well, and nausea related to hemodialysis patients. But as far as pain, there's some evidence, again, low quality, to support their role. Very complicated in terms of legal and regulatory issues. In green states, states that have more permissive cannabis ruling, they are often used, but in those published reports, they appear less effective for acute pain compared to chronic pain states. Lots of problems with euphoria, temporospatial and memory performance disruption. It's called false novelty, is how I always heard it described. It was very interesting. A cannabinoid expert at UBC was describing the experience as everything seems all new again because your memory doesn't remember that you've seen those, to use the example, rainbows on soap bubbles. You've seen it a billion times. Suddenly it looks new to you again. So that she calls that a false novelty. That may be good because the world is full of wonder that we may not look at, but it's not great for memory. And then, of course, it's a very complicated issue as far as patients, providers, referring to legal issues at this point that have yet to be fully untangled. So this is for your handout for you to take a look at if you want to get a quick summary. The drug class, the major effect on neuropathic pain, which is what the data is published on, and I would consider any centralized pain state a neuropathic pain state. Pardon me, neurologists in the audience, but I think we can make that analogy. Numbers needed to treat and numbers needed to harm, and the mechanism of effect. So quick summary for those of you who, and you've got this handout to be able to make a quick reference as to what you're doing and what you're using these drugs for. So bottom line, non-opioid effectiveness is at least as good, if not better, than opioids, often with lower risk. Tricyclics are more effective for neuropathic pain than any of the other categories studied. The best evidence for the non-opioids are in fibromyalgia, diabetic peripheral neuropathy, and headache. Very limited randomized control trials for the non-gabapentinoid anticonvulsants. Limited evidence for reducing hyperalgesia, although there is some to support their use. But side effects are common with the sodium channel, and you need to monitor, and including the subjective reports of our patients on the antidepressant drugs. More information on the COPE-REMS program, please follow this link. It'll get you to a wonderful training that Dr. Sullivan has put together, and this program is in part sponsored by them financially to allow us to provide this material.